I'm Brad Smith. I work at NephCure. I'm in our fundraising division, so I help out with a lot of our fundraising events across the country. But it's really my honor today to introduce Dr. Beck and welcome everyone to the it's easy for me to say, Membranous Nephropathy, sharing breakthroughs and recent discoveries. And I still probably butchered it. But again, just want to say, feel free to put questions in the chat. At the end of his presentation, we'll go over and hopefully answer some of those questions. But a little about Dr. Beck. He's an adult nephrologist at Boston University Medical Center. Dr. Beck completed his internal medicine residency and nephrology fellowship at Boston Medical Center. He joined the renal section in 2006 and continues to conduct basic science research in the laboratory of Dr. David Salant on the pathogenesis of membranous nephropathy. He has expertise in immune medicated glomerular disease, and he is also one of the two medical chairs for the upcoming membranous nephropathy, the ELPFDD in August, which is a mouthful to say. But thank you so much for being here today, and it's all yours, Dr. Beck.
All right, thank you. Can you still hear me? Because a lawnmower just started outside. Yep. I figured I should use the headphones so we're a little more focused.
Absolutely, can still hear you.
Perfect. So my name is Larry Beck. As mentioned, I'm at Boston Medical Center in Boston. And thank you for those participants on the call. I hope this will be informative. Oops, I always lose how to go forward here. Okay, so as many of you know who've had this, the typical path to the diagnosis is someone notices that they have swelling in their legs, maybe some weight gain that's unexpected, maybe foaming or bubbles in the urine. And at some point, a doctor tests the urine and it's, half a gram, 5 grams of protein. These days, there may be a blood test that can suggest the presence of MN. MN is the easier way to say membranous nephropathy for next time. Then you either have a clinic visit with a nephrologist, or you get the kidney biopsy first, or sometimes those two are reversed. And the kidney biopsy specimen shows membranous nephropathy. MN, membranous nephropathy, tends to be more common in middle age. I think the average age of diagnosis is about age 50. So people younger than 50 can certainly get it. But if you have the nephrotic syndrome in children, that tends to be minimal change disease, FSGS. Very rarely can be membranous nephropathy. And for those of you who have had a kidney biopsy, or those who want to learn more, basically a small piece of kidneys taken out with a needle through the back. It's a little, about centimeter and a half long, spaghetti noodle size piece of tissue that the pathologist will cut into 3 sections. One goes and gets processed just to look under the regular microscope. Another sample is frozen, and that's used for special stains that are, I'll show some images later, the immunofluorescence. They can look for certain proteins in the tissue. And then one goes often, and not all centers do this, but in the US most do, they go for the highest power microscopy, the electron microscope. I want to emphasize, just like FSGS, people are probably hearing about this in another breakthrough, membranous nephropathy is really just a pattern. This is what the pathologist sees under the microscope. So this is the immunofluorescence, or this dark background, and the granular deposits is what we commonly see as membranous nephropathy. If you have a different condition and the kidney biopsy shows a scar, that's the FSGS lesion, and then there's some more inflammatory lesions. This doesn't really tell us what is causing it. It's just sort of, this is what's happened, this is what we see. So there are different types of membranous nephropathy, and I think in the last few years we're finding out there are many more types. There is one common one which I'll talk about. So just sort of basics of kidney, how the kidney works. Why do people get membranous nephropathy? I like the image of a kidney filter, right? So you have a filter, you put in the coffee, You put the water through, and you shouldn't get the coffee grounds in your coffee. You should just get the water and the chemicals that are coming out from the coffee grounds. So membranous nephropathy is a leaky filter. And then the next question is, so what's causing the filter to be leaky? And this is a schematic. Many of you may have seen something like this of the glomerulus. The glomerulus is the kidney's filter. There are about a million in each kidney, although there's some variability. Some people have more, some people have a little bit less. But glomerulus is Latin for little ball. It's a little ball of blood vessels. And basically the tiniest blood vessel, will bring in the blood cells and the fluid through this collection of tiny blood vessels, the glomerulus. And the pressure that's, the heart and the blood vessels are causing a little bit of pressure just to keep the blood moving. And that pressure will force the fluid out. And normally in there is just the chemicals and the water and the salt that it will eventually become the urine. And the filter is, there are a lot of different layers of it, but the cell type that really maintains this filter is called the podocyte. And it's called that because it has lots of feet. It's basically a foot cell. This is a very high resolution image that just came out in a review that one of my bosses wrote in the New England Journal. And you can see how sort of finely delicate structure this cell has. And basically, we call these foot processes that this foot cell, the podocyte, has, interdigitate. So we're using a different, instead of the foot, now we're talking about the hand. So the fingers interdigitate, and basically this is what the podocyte is doing. It's wrapping its final arms around the blood vessel, and those tiny little feet come together to make the filter. So the fluid comes sort of between these little slits, and we call these slit diaphragms. And this is where protein that is in the blood should stay in the blood. But in many of these diseases that NephCure is sort of making awareness about and then trying to get patients into trials, the filter is leaky. And that's because these cells, when they get sick, this is a cross section of these feet landing on the filter. And between them, there are these tiny little pores that keep the protein back in the blood. But when the cells get sick, they retract their processes. And then the junctions, the connections between the cells don't have that special filter. So the protein really leaks through these gaps between the cells. And this is just another schematic I created. The podocyte, and then its neighbor cell, so that one podocyte's in green, another podocyte's in blue. A healthy one is keeping the protein in the bloodstream. When there are genetic causes of kidney disease, podocyte injury, when there are things outside the cells, we'll talk about antibodies affecting the podocyte, but in diseases like minimal change disease, FSGS, we don't really know what the protein is that's causing the cells to be sick. The podocyte loses its foot processes. It becomes this simplified blob. It develops these little hair-like projections on the other side. That's a sign that these cells are sick. And then the protein is leaking out around the cells. And that's why there's so much protein in the urine. And this is what a pathologist would see in a patient with membranous nephropathy. So panel A is just something under the light microscope, and take my word for it, this little blood vessel here, the lining around it is thicker than normal. So the membrane is thicker, and that's why we call this membranous nephropathy. If you look at higher power and you stain the kidney with a dye that stains the extracellular matrix, the protein part of this filter, what you can see is tiny little holes and tiny little spikes. That's because the part that's not staining, these holes, is full of antibodies and proteins, and that's what these tiny little dots are. They're granular deposits, and here's a podocyte, and you can see sort of these hair-like projections on one side. It's not a healthy looking cell, trust me. And the reason it's not is because these darker areas, these are these deposits that light up in green here, and the deposits that show up as clear in panel B, and they're full of antibody and some protein. And this is what investigators had been trying to figure out since the first animal model of this came around in 1959. It's called Haemon Nephritis. And many people studied this rat model, and we knew that the rat developed similar types of deposits, and we knew that there were antibodies, which I'll talk about, and they finally figured out in 1985 or so what the target protein that was ending up in these deposits was. Unfortunately, that wasn't relevant for human disease. So many of you know about antibodies. I think in the last year, talking about vaccinations and stimulating our immune system so we make antibodies against COVID, we may have learned a little bit more, but our body has immune cells called B cells, and their job is to make specific antibodies. These are proteins that circulate through the blood. They specifically attack different targets. So, for example, you get COVID or you're vaccinated against COVID, there will be a proportion of your millions and millions of B cells in the body that will make antibodies, these little Y-like structures that will target a specific protein from that COVID, the spike protein. Or if this is a bacterium, you might have a antibody against E. coli or something. So the immune system is protective. But in certain occasions, and membranous nephropathy is one of these, the body turns against itself in an autoimmune fashion and makes antibodies that can target your own body's tissues. And in the case of membranous nephropathy, it's targeting the podocyte, that foot cell. Normally, our bodies have mechanisms to turn off these B cells, but for some reason, and we're not really sure why, in some patients, some people, the autoimmune B cells just are able to keep making their antibodies and attacking the body. So this is where I started my research. I came into the laboratory of David Salant, who had worked with this rat model for decades. And in 2004, I think that's when I was starting my research fellowship in nephrology, we still didn't know what the target was in human disease. So to simplify what I did with David Salant is we had a number of patients with this disease. At that point, it was called idiopathic membranous nephropathy. And we collected basic blood samples, just a single tube of blood, like your doctor might check for if you're immune to something. And we took those and we asked, were there antibodies in the patient serum, the blood, that could react with a specific protein from the kidney filters, the glomerulus? And to get the human kidney filters, we occasionally get human kidneys that can't be transplanted for some reason. Either the kidney is too sick, or there was a question of infection and they didn't want to give that kidney to someone. So the New England Donor Services has set up to get us some of these kidneys. And we're very thankful for their help in this. And we can take specifically the glomeruli and dissolve them in detergents so that all their proteins are separated. And then you can ask in various ways, is there a specific protein that the majority of patients with membranous nephropathy will recognize, but patients with other diseases or healthy patients, healthy people, don't recognize? So this was years of work, but eventually with help from others, we figured out that the major protein that's recognized as the target antigen in membranous nephropathy is a protein called PLA2R. And this is another difficult thing for people to say. It stands for something even more difficult, the M-type phospholipase A2 receptor. But PLA2R or PLAR2, as some people call it, is a little easier to say. We had never heard of this protein. It just came up on one of these lists. And we reached out to a colleague in France, Gerard Lambeau, who had he had discovered this protein in 1994. And we asked him, like, we've never heard of this. Could we get some samples? And he was very collegial and sent us some things we could work with. And we discovered that the antibodies in the patients of membranous nephropathy actually did recognize this protein. It's a folded protein. It sits on the outside of the cell. So antibodies that are circulating and come through the kidney filter can attack it. And that's what we think is happening in this disease. And so this is the protein. I couldn't make it in a little ball form, so it's a stick figure. But the GBM is the glomerular basement membrane. It's the protein, sort of the dead, the not made of living cells portion of the filter, just like a little piece of cardboard. And water and chemicals can filter through it, and actually antibodies can slowly filter through it. And ultimately, if you have these antibodies in your circulation, they'll find the PLA2R protein at the bottom of those podocytes. And over time, the protein comes off the cell, complexed with this antibody. And part of our immune system called the complement system, it's sort of like the blood clotting, the way our blood clots, but it's a different system intended to get rid of bacteria and viruses. So these complexes of antibodies and proteins, which often would be viral proteins or bacterial proteins, stimulate this system. And basically a series of reactions occur, and these big channels get inserted into the sort of the membrane, the cell edge. If this were a bacterium, that's a good thing, right? You'd basically poke holes in the bacteria and it would die. When this happens to our own cells, the cells don't die, but they become sick. And that's that sick podocyte image that I showed you. And this keeps going on as long as there are these antibodies in the circulation, which is why our therapeutics, our drug targets, try to get rid of these antibodies in the circulation. One of the other good things about knowing what the target protein is this is about 80% of the major sort of idiopathic, or now we call it primary membranous nephropathy, will have antibodies to this protein. So the pathologist in the past would stain for IgG, is another word for antibody. So we'd see the antibody in these deposits. Now we can take that biopsy tissue and ask, is there the major target protein, PLA2R, in the deposits? And this tells us that we're dealing with this particular form of membranous nephropathy. We now know there are other forms, and we're not all centers can test for all the forms yet, but I think we're getting there to find out exactly what type of disease you might have. And our paper, we described this in 2009. It was quite simple at that time. You know, we had a few patients. This shows in December 2005, this patient had antibodies that reacted with this PLA2R protein. And then in later time points, there was no more antibody. And over that time course, the protein in the urine went from 5 when the patient had the antibodies to 2.5 to a remission. So the urine protein went away, and their blood albumin level, the main protein in the blood, started going back up again. So that's good. And we had a few patients like this. And with some other collaborators, we took 3 paired samples that had been collected in the past from patients with membranous nephropathy that had active disease, had the nephrotic syndrome, had been treated and went to a remission, and then had a relapse. And we showed that when they were in remission, largely the antibodies went away, these anti-PLA2R antibodies. When they had active disease or when they had a relapse, that's when the antibodies came back into the blood. So we could use this to say, is a patient active at the antibody level? Now, in comparison to other diseases that children and adults get that cause large amounts of protein leakage, like minimal change disease. So that particular disease can come on fairly quickly. So within a week or two, someone can go from not spilling any protein in the urine to having, swollen face, swollen legs. And then you treat them with something like corticosteroids or prednisone, and within a few weeks, it goes away. Membranous nephropathy, so if that's the hare in the story, membranous nephropathy is the tortoise. It moves a lot slower. So by the time someone shows up at their doctor with membranous nephropathy and lots of swelling in the ankles, it's probably been 6 to 12 months that disease has been there. Similarly, as we hope that it might go away on its own, or we treat it with immunosuppressive medicines, it may be months to years before we see that the final loss of protein in the urine. So it's a very slow moving, long duration disease. And the reason is you have this sick podocyte, you have all these deposits that are stuck, and they stay there for probably years. It takes a while to get back to this normal structure where the podocyte can put its foot processes back together and reestablish the barrier that it once had. So we early on noticed that the antibodies, if you followed them in the blood, this anti-PLA2R, needed to come down and disappear before you started to see the protein also come down and disappear and get to a partial remission, which is less than 3.5 grams per day of protein, or to a complete remission, which is essentially nothing, less than 1/3 of a gram. And we called this point, actually we didn't call it at that time, but people have started referring to this as immunological remission versus a clinical remission. So immunological remission is when the antibodies disappear from the circulation. And we knew this because my colleague Fernando Fervenza at the Mayo Clinic and Dan Catrin in Toronto had collected a number of blood samples from patients with membranous nephropathy who they had treated with rituximab, a drug that targets the B cells. And this is just one of those patients. You can see that over at time 0 and 3 months and 6 months after treatment, the anti-PLA2R is going down, and that's shown in red here. And then if you look at that particular patient's protein in the urine, that comes down with a lag time of 6 months later, and it doesn't get to 0 until 24 months, whereas the antibodies disappeared by 12. So there's this lag time between what the antibodies are doing and what the protein in the urine is doing. And this is, don't pay attention to all these details. It's sort of a complex slide, but it just shows that at the beginning of disease, the autoantibodies, these anti-PLA2R, are increasing. So there may be a time when you have the antibodies in the blood, meaning you're seropositive, but you really don't have any clinical signs. If a doctor happened to check the urine, maybe there'd be a tiny bit of protein, but generally you don't have the swelling, you don't have the weight gain. And it's really not until the active phase when the protein loss in the urine has built up, the swelling brings you to the doctor, that sort of everything is active at that point. And then either spontaneously, about 1/3 of patients will go into a spontaneous remission. The antibodies start falling here in the immunologic recovery, or you get treated and the antibodies start falling. So that happens first, and then you hit this immunologic remission, and then the protein will come down later. And the important thing to recognize here is that there are a proportion of patients, as I said, this disease started maybe a year ago, who get their biopsy and they're still proteinuric. So the blue here is protein, but their antibodies may have already disappeared by then. So if you find you don't have the antibodies in the blood, it's very important to look at the kidney biopsy tissue, because if there's PLA2R within the deposits, but it's absent in the blood, that's a very good sign. People like this are likely to go into a clinical remission, meaning their proteinuria is going to go away a lot quicker. So, you can ask, so I leak 5 grams of protein a day, so what? Well, there are a few consequences. One is that the kidneys, when it's leaking protein, also like to hold on to salt. And the salt is what causes the swelling. So the more protein the kidney's losing, the more salt the body's holding on to, and the more swelling occurs. The nephrotic syndrome in general, the loss of lots of protein, can also cause high cholesterol levels. That can be important for your vascular, your blood vessel health. For some reason, membranous nephropathy, of all the disorders that cause nephrotic syndrome, has the highest risk of blood clots. So these can happen in the legs, in the kidney vein, or worst, in the veins of the lung. And the one thing we all worry about is the more protein you lose in the urine, the longer that's occurring, the more likely it is you're going to lose kidney function over the years. And I have another slide that's a little less complicated than this, but my colleague said, make it simple, have the kidney turning into a rock. So a kidney over years, if you're leaking 5-10 grams of protein, will become very scarred and won't work anymore. We know that from studies, and this is the slightly more complicated slide. If you look at, it's a little counterintuitive, but if survival free from renal failure. So if you're up here, this is the best outcome. This means over time, you don't need dialysis, you don't need a kidney transplant, you don't reach sort of very advanced chronic kidney disease. And the people who do best are the patients who achieve a complete remission, meaning they get their protein down to less than 1/3 of a gram. If you can only get to a partial, meaning less than 3.5 grams, you still do pretty well. Certainly for the first 5-10 years. Over time, some of those patients end up with worsened kidney function. What you definitely want to avoid is not having any sort of clinical remission. You can see that these patients, starting at 2-3 years, start losing kidney function. And by, say, 15 years, if patients haven't had a remission, only 30% of them have significant sort of good kidney function left. 70% have lost kidney function and may need the dialysis or transplant. So in terms of our treatment goals, we do everything we can to lower the amount of protein in the urine to help protect the kidney. We also want to address the symptoms, and edema and weight gain is a big one. We want to turn off the autoimmune attack on the kidney, and all of these things can help stop the ongoing damage to the podocyte. So again, we'll go back to the coffee filter idea. And here I also want to talk about sort of the rate at which the water is going into the filter. And I'm going to use a different analogy. We're going to use the garden hose that has holes in it to water the grass, etc. So when you have the faucet turned on at some water input, you're going to have a little trickle of water coming out. How do you make those spouts of water go higher or further? One, you can turn up the water, or you can put a little kink in the hose or clamp off the end, and then you get the water coming out a lot more forcefully. If you want to turn it down again, you just turn down the faucet and you unkink the hose, and the filter goes back to normal. So the same thing is happening in the kidney. The kidney has a very exquisite system to regulate the blood flow in and the blood flow out. There are muscles that can contract in each of these in and outputs. So when the kidney wants to increase pressure, and this happens if you're dehydrated, you have low blood volume, you've been bleeding, your blood pressure is low. Some people are born with not enough kidney filters, so the extra ones, the remaining ones have to do more work. So the kidney will turn up the blood flow in, and it will pinch off that sort of output. So the pressure goes up and it can filter more chemicals out. That's good if you're getting rid of potassium. It's bad if you're already leaking, and the yellow dots here are the protein. If you're leaking protein and the kidney is increasing that pressure, you're going to leak more protein. And we know that's bad for the kidney. So we can interfere with the kidney's mechanism for clamping off on that output. And these are the drugs that many of you may have taken. ACE inhibitors such as lisinopril and angiotensin receptor blockers like losartan. they take the pressure off the kidney filters and they keep them healthier for longer. We're finding that in new diabetes medicines, these SGLT2 inhibitors, which basically caused you to urinate out sugar, also have the same effect on the kidney, but at the input end. So these may also be protective in the future in patients with membranous nephropathy, even without diabetes. So this was discussed this morning, this afternoon, in the intro, that glomerular disease specialists are the ones you want to be seeing. So I liken this to, if you have a primary care doctor, general internal medicine doctor, there are other specialties within medicine that he or she may send you to, right? A cardiologist, an endocrinologist, a rheumatologist, or in the case of kidneys, nephrologist. So in nephrology, we have the same thing. Some nephrologists are interested in cystic kidney diseases or kidney stones or blood pressure. But there are, I guess it's only 200 to 300 based on the introduction, glomerular disease specialists that really are comfortable and know a lot about these diseases. So what happens and why come to a glomerular disease clinic or a nephrologist who specializes? One, some of these, now membranous nephropathy is pretty limited to the kidney, but there are other diseases like lupus kidney disease that a rheumatologist who specializes in these more general autoimmune disorders like lupus may see you at the same time. So you can see a rheumatologist, a nephrologist, sometimes a dermatologist. So these multidisciplinary clinics. The glomerular doctor can arrange, sometimes perform him or herself, and certainly interpret the biopsy results. There is specialized testing, special blood tests. Genetics, we're using a lot more genetics in general for glomerular disease. For membranous nephropathy, it hasn't quite come into a useful realm yet. And certainly there are specialized treatments and infusions that a glomerular doctor may prescribe, and the opportunity to get linked into clinical trials, as you've heard about. As all of you probably know, it's walking a tightrope, the balance between the disease and its effects and the treatment and its effects. So what do we think about in terms of membranous nephropathy? You want to control the symptoms, especially the weight gain, the swelling, the fatigue. There are concerns about other associated problems like these blood clots. There's been a higher association of cancer in patients with membranous. Some of the different target antigens may be more or less linked with cancers. PLA2R is generally not, but there are others that we're learning about that may be more linked. Some of these people with membranous nephropathy just have so much swelling that the pills aren't going to control it, and they have to come into the hospital to get IV diuretics or water pills. We talked about the risk of losing kidney function over time, and then there are the risks of the treatment. Certainly there are quality of life concerns. Fatigue is a big one in membranous nephropathy, although it's not something that as a doctor I have a great solution for or talk about or the patients bring up, but I think it's an important one to realize. Can I do my job? Can I participate in my normal activities? Sometimes that weight, the 15 to 20 extra pounds that may end up in your legs really can limit what you're able to do. So ability to work, family impact, the burden of treatment, what do I need to do in my diet, and just an overall anxiety about my kidney health in the future. I'll talk a little bit about symptoms. Let me just check on the time. I think we're good. The main things that patients will complain to me about is their edema, in the face and the legs, worse at the end of the day tends to be cramping, fatigue, blood clots. Hopefully they're not coming in saying, I have this pain in my chest and I may have a blood clot in my lung. That tends to be pretty severe, but it's something that we do discuss. So the edema, dietary salt restriction, I'll talk a little bit about salt versus water. The diuretics are key components of our treatment regimen. taking them at the right times. They're longer acting, shorter acting diuretics. Furosemide or Lasix tends to act quickly, so you may need it twice a day. Torsemide acts longer, so sometimes you can get the coverage through the whole day. Cramping is a big thing. Probably similar to the cramping that people will get if they're out running on a hot day, related to the amount of salt and water you're losing in the urine, especially with the diuretics. There's no great solution. I tell people to stretch, drink water before bed, just make sure they're well hydrated. Sometimes vitamin E can be useful. One patient claimed that the spray-on magnesium spray helped, and certainly we link it to low magnesium levels, so maybe that's true. As I mentioned, fatigue is common, but we don't have a lot of great solutions other than trying to get the disease under control, getting rid of all that excess weight, fluid in the legs, taking a diuretic so you're not interfering with your sleep. Don't take your diuretics at bedtime. The water tends, all that fluid that collects in the legs during the day, unfortunately, when you put the feet up and sleep at night, that will enter the circulation again and your bladder will fill eventually. So, controlling the edema may eventually lead to a better night's sleep. And blood clots, sometimes given the amount of protein that's leaking and the level of the albumin in the blood, we recommend blood thinners like warfarin or Lovenox injections. So one common misconception is that the fluid in the legs is due to too much water, and people stop drinking a lot of water. It's actually the salt. There is water there, certainly, but when you drink water, it goes everywhere in the body, into our cells, into the bloodstream, into the tissue. So water isn't going to fill up the legs quickly. It's really that excess salt. So anything you can do to limit the sodium in your diet, make sure you're taking the diuretics that your doctor's prescribing a good dose, will help the swelling. This is just another reminder that we need to balance the current symptoms, the edema, the fatigue, with the side effects of treatment. But we also need to think about long-term kidney outcome, getting that protein down to a level where the kidneys are going to be safe 10 years from now, versus the longer-term consequences of treatment. There's one particular drug, cyclophosphamide, that we know has future risks of blood cancer, so we really try to limit the dose that we give patients. And this is generally, if you show up with membranous nephropathy, your initial episode, we call this the rule of thirds, that a third of the patients will go into a remission over some period of time on their own. A third of the patients will maintain good kidney function, but they'll continue to leak protein. And these are the ones we need to carefully think about. When do we introduce the treatments? And then a third, even despite treatment or not getting the right treatments, will progress to chronic kidney disease or end stage. And in that case, if you do get a kidney transplant due to membranous nephropathy, the disease can unfortunately come back in the transplant. Fortunately, we know how to expect it. Those people that make it to a clinical remission, the good news is 70% will remain there and won't have any more episodes. The bad news is 30% will have one or more relapses that need to be treated again, most likely. This is a little busy, but this is how I think about treatment. So every patient that comes to see me, I focus on blood pressure. I make sure they're on an ACE inhibitor or an angiotensin receptor blocker. If they need diuretics, if their cholesterol's up, I put them on a statin drug and recommend the dietary sodium restriction. Many patients will, with that treatment, end up with protein levels under 3.5 grams. Really, they're asymptomatic, so we just watch them on that therapy. If, or from the beginning, if they end up in this moderate risk group, so they're good kidney function, but they're leaking 4 to 8 grams of protein, the guidelines tell us to think about these anti-PLA2R antibodies. There are no great cutoffs yet. Clearly, if the levels are not going down on their own, patients should be started on immunosuppressive drugs. And I tend to like these anti-B cell agents like rituximab, but I've had success with things like tacrolimus or cyclosporin. They just take a little longer to act. And then the highest risk patients are those patients that have declining kidney function, their creatinines are increasing, or they can't get less than 8 grams of protein, or if they have high levels of anti-PLA2R that are going up. These are the ones that really need to be treated quickly. Rituximab is possible, but if things are going downhill quickly, these heavy-duty agents, these alternating months of cyclophosphamide and corticosteroids, which is called the modified Ponticelli regimen, is what I like to use. I'm not going to go through all of these side effects of treatments, but every drug has side effects. And NephCure knows a lot about corticosteroids, and all these glomerular diseases are treated with prednisone. And there are lots of problems with corticosteroids like weight gain, skin changes, diabetes, bone losses. So we try to minimize that. Cyclophosphamide I talked about, there's a high risk of infections. The blood cells made in the bone marrow can all go down. People get sick to the stomach. There's a risk of infertility and future malignancies. So we're trying to stay away from this as much as possible. Rituximab, about 10% of the people get allergic reactions at the time of infusion. And then things like tacrolimus or cyclosporin, there's a risk of the kidneys acutely getting worse, high blood pressure, other problems with hair growth or hair loss. So nothing is unfortunately without side effects. Fortunately, we're learning, the last 2 years has been very important for membranous nephropathy. We've had trials reported, and we've had new target antigens reported. And some of these trials, so GEM-Retux was a French study. GEM is the acronym in French for membranous nephropathy. That showed us that rituximab is better when added to supportive therapy, and that by 6 months, we can already see a drop in the antibodies, and that's predictive of future outcome. I think the biggest trial that came out in 2019 was Mentor. This is membranous nephropathy trial of rituximab. It was a 2-year trial pitting rituximab, the IV medicine that targets B cells, to the oral pill you take twice a day, cyclosporin. And although the outcomes were similar at 12 months, there were about 50 or 60% remissions in each group. When they looked at 24 months, and by that point, both of these drugs had been stopped. It was an observation period. The number of remissions in the rituximab group just continued to be maintained, but those patients that had gotten the cyclosporin, basically all of them relapsed. So they didn't maintain their remissions. So this trial showed that rituximab is superior, a better drug than cyclosporin. And by sort of analogy, we think that tacrolimus would be in the same category as cyclosporin. There's a trial called Starman that was done in Europe. Basically, it showed that the oldest treatment, which is this modified Ponticelli regimen, alternating months of cyclophosphamide and steroids for alternating for 6 months, was a good treatment. And unfortunately, the combination of tacrolimus and rituximab, neither of those was dosed as we would dose them if we were designing a trial these days. But it worked. It just wasn't as good as this old treatment. And then finally, the Recyclo looked at giving 2 doses of rituximab at sort of time at day 1 and day 15, 2 weeks apart, to this modified Ponticelli regimen. And it actually showed that they're quite similar. I think the investigators hoped that rituximab would come out having less infections, and the 2 were sort of equal. So if you're on rituximab, we still need to watch for infections. But it did show that I think we're getting there, and we're matching these time-tested treatments. So what's coming in the pipeline? There are more biologic infusion agents, meaning you get it through the IV, medicines that target the B cells, sort of improved versions of rituximab or drugs that might target the B cells along more of their life. I'll talk a little bit about the complement inhibitors. There's some thought about the way that B cells talk to other immune cells that we might be able to interfere with. And then the holy grail is really, can we target those B cells that are making the bad autoantibodies? So this is what normally happens in our immune system. You have a B cell that's making, for example, antibodies against PLA2R. That B cell needs to talk to a partner cell called a T cell, and they sort of mutually influence each other with this interaction. The T cells, which can be regulatory or can be more causing inflammation, those cells proliferate and B cells turn in and they can secrete their antibodies more efficiently. So there's some thoughts about targeting this process. We don't have that yet, but people are looking at that. This is sort of the time period when we might think about complement inhibition. And there are a lot of companies working on complement inhibitors now. So I've been talking about how immunosuppressive therapy will take your circulating in the bloodstream anti-PLA2R antibodies and cause them to decline and decline and disappear. But even if they're at low levels, they're still targeting your podocytes. You're still forming these deposits under the cells. And that process of complement activation is what's injuring these cells. So if there were a medicine you could take that is stopping this injury process, that might allow your kidneys to heal, even as the other medicines are taking care of the antibodies. So there are a few trials that are going on in this space using complement inhibitors in membranous nephropathy. We sometimes think about treating a disease as warfare, and now knowing what's going on in the Middle East and Israel and Palestine, I hesitate using this, but I still think of the cyclophosphamide steroid Ponticelli regimen as really just, over aggressive. It's killing lots of cells in the body, and it's effective, but I don't think we need that degree of power. Then you have a more, drone strike. So the rituximab is targeting a portion of the immune system, the B cells, but again, that's very broad, and there's a lot of collateral damage here. Their B cells, most of them make good antibodies that protect us. So we're using this therapy to treat, those few cells that are making the antibodies that cause membranous. I think we're able to follow them in many cases, and we're getting towards a precision therapy. But what we really need is the ability to kill the B cell that makes the antibodies that cause disease, so antigen-specific therapy. This is still years and years off, but there is a company, and this was on their press release on May 3rd. They're developing a clinical trial for another autoimmune disease where their plan is to target the B cell that makes a specific autoantibody. But they did announce in their pipelines that the drugs that they're thinking about is making a therapy that will get rid of these B cells making the anti-PLA2R membranous nephropathy causing antibodies. So someday. So I may take questions, and are there questions available, or I could go through some of these as stock questions.
Go through those. I'll look through the comments again here.
Okay, good.
But if anybody does have any questions, feel free to please put them in now in the chat function.
So these were suggested as things that do come up. And people say, okay, if I do have the antibodies that can be followed, how often should they be checked and during and after treatment? I think certainly they're good at diagnosis. So that's a one-time thing. They're useful if they're going down and a nephrologist wants to avoid immunosuppressive treatment, and then you can check them every 2 or 3 months. During treatment, say you start tacrolimus or you start rituximab. Similarly, it's probably when you come back to the clinic visits every 2 to 3 months, see if they're going down, or if they're not, do we need to change the medicine? After treatment, I don't routinely check. Once they get to an undetectable level, I'm pretty sure they're not going to rebound immediately. So I go by symptoms, and if the protein in the urine starts to go up again, or if there's a little bit of swelling, then I might check them again just to see if there's been an early relapse. I think the bigger problem is those patients with membranous nephropathy, and that can be 20, 25%, that don't have this common form, this PLA2R associated form. Again, the first thing, if you do a blood test, if you have 4 grams of protein in the urine, you get the blood test for anti-PLA2R, it's negative. If you've had a kidney biopsy, it's very important to check the biopsy for the PLA2R in the deposits, because if they're there and you don't have the antibodies, that's good, and you can just keep watching. If there's no PLA2R antibodies and there's no PLA2R in the biopsy, then you have to think, okay, what type of membranous nephropathy is this? And in 2014, we and some colleagues identified another protein called THSD7A. That's probably about 1 to 3% of membranous. And then in the last 2 years, as I mentioned, there's been an explosion of new antigens. NEL1, protocadherin 7, exostocin, HTRA1, so we're just finding out about all these new targets, and specialized pathology groups like the Mayo Clinic or Columbia or Arcana can do some of this specialty staining of the biopsy. I don't think we're there yet on the blood tests, but hopefully in the future we'll be able to follow these new autoantibodies, which seem to work the same way. They're there when you have active disease. If you get treatment, they go down, and then the disease follows. So I think we'll know a lot more, and we'll have more clinical options for following these in the next few years. Some people wonder how long they have to be on immunosuppression. That's really up to the medicine. If it's working, rituximab, some people may need like the single initial treatment, and then the disease goes away. Some people may need treatment at 6 months to 12 months before the disease starts to resolve. What we know about things like tacrolimus and cyclosporin is probably patients need to take that for longer, maybe 24 months before we start to taper it, especially if you can follow the antibody levels. Because if you take it for 12 months and stop it, most patients will have a relapse of their disease. Diuretics is, as long as there's significant protein leakage, swelling, I think I'd keep my patients on the diuretics. If things get better, I'm certainly happy to stop them. And then blood pressure, remember that this disease takes a long time to go away. And it's very important to keep the blood pressure controlled, even after the protein has gone away. There's some reports of patients who had absolutely no protein in the urine after they were treated for membranous nephropathy. And then a year or two later, they sort of went back to their old habits and were eating a lot of animal proteins and salts, and the disease came back, and they had grams of protein in the urine, and they got another biopsy, and what it showed was they still had these old deposits that were trying to resolve, but really the high blood pressure, the salt, pushed this filter into becoming leaky again. So I would argue that staying on the blood pressure medicines, especially the ACE inhibitors and the angiotensin receptor blockers, is important even after disease. And then, I think this is a very exciting time for membranous nephropathy. There are a number, I think the number was 7 that was quoted earlier today, is trials going on in membranous nephropathy. We're learning a lot more about the targets in disease, learning new things about what's happening in the kidney. So I think it's a great time for this disease. Unfortunately, we'll have to wait a few years before all of these new trials and drugs and ability to monitor the disease come to fruition, but they're coming. So I think that's my, I do want to re-advertise for this patient, sort of the patient voice, patient-focused drug development that's NephCure and National Kidney Foundation are sponsoring for the FDA, sort of to get the patient voice about burdens of disease, clinical trials, types of treatments that we need. So please sign up for that. It's in August 27th. You can find it at NephCure site. And then I'll leave the sponsors up. And I'm not going to go to the up next, but
Well, we do have before we get to the thanking our sponsors and thanking you, of course, we do have a few questions here.
okay, I'll put it back to this one.
Yep, fair enough. Yeah. And I hope I say this correctly because I butchered everything else today. But one of the questions is, what do you know about Acthar gel, ACTHAR gel?
Yeah, so that's a very good question. And I didn't put it in because it's not a first line therapy. So Acthar is the one US company that makes this formulation of a hormone that we all make. It's called ACTH, Adrenocorticotrophic hormone. It was actually the first drug. ACTH was used in the 1950s to treat nephrotic syndrome, and it's, it probably wouldn't have gotten approved today, but the FDA in the 1950s approved it because it did seem to help nephrotic syndrome. And so now there's a purified version of this. It's an injectable drug, and patients, I think it's like a 3 times a week injection. Some initial trials in Europe were very promising. They compared it to the Ponticelli regimen with the cyclophosphamide, and it seemed to be equivalent. The US version isn't quite the same, but we know from some small trials that it can cause the decline and disappearance of anti-PLA2R. Some nephrologists prescribe this. It seems to work, but it's probably not a first-line agent. So.
Perfect. Thank you. All right. Another question is, rituximab treatment was successful in diminishing my PLA2R a couple years ago, and I have been on losartan ever since, but my protein loss is still significant. PLA2R test is still negative. I'm 35 and want to get pregnant in the next year or so, and concerned about infertility risk of other treatments. Can you speak to infertility risk of treatments versus risk of MN on pregnancy?
Yeah, certainly, the risk of any proteinuria, of any kidney disease during pregnancy puts both the pregnancy at risk for, preterm birth, small intrauterine growth, preeclampsia, high blood pressures during pregnancy. And pregnancy puts that extra stress on the kidney, so it can get worse. Things like losartan, and we don't want to use those during pregnancy either. So I definitely would not recommend something like cyclophosphamide, because that can definitely cause early infertility. Rituximab prior to pregnancy, that'd probably be my choice. Just try another cycle of that. There's also the question is this proteinuria ever going to go away? Sometimes it was very high at 10, 15 grams. You get rid of the antibodies, you get down to 3 or 4 grams, and you're just sort of stuck there because there's been scarring in the kidney, and that's not caused by the antibodies. That's just residual damage to the kidneys. In that case, blood pressure control during pregnancy. Sometimes I look at other things like, did the cholesterol levels get better? Did the serum albumin come up closer to normal? And that might tell me that this is more of a structural kidney scarring that's never going to completely go away. We can use medicines like cyclosporin and tacrolimus during pregnancies if that becomes necessary. So I think, speaking to your nephrologist, there are other specialists who deal with glomerular disease and pregnancy that your doctors could speak with. But that's a very important question about how to move forward in that case.
Great, thank you. Next question. Is it worth finding out what antibody is the cause if it's not PLA2R, or should MN be treated based on protein level regardless?
Yeah, I think at this point it's quite a tedious process to find out what else it could be. And clearly fortunately, we know sort of the time frame of when medicines work based on the anti-PLA2R story. So I would still recommend in that situation, giving tacrolimus for maybe 24 months, or giving a few cycles of rituximab, or someday I hope that will be easier. But up till 2009, when we found PLA2R, everything was treated based on the amount of protein. Sort of, is it going down? Is it going up? Should we modify treatment? So that's still, that's what leads to the bad outcomes. We know that 10 grams of protein over time is not great. So that's why we treat it. It just makes it a little easier if you do have something to follow, because in that case, say you found there were antibodies to, let's call it NEL1, which are also in the bloodstream. You give a treatment and you watch those coming down, then sort of that's your answer. You don't have to wait the next 6-12 months before the protein is fully down. It just gives a quicker answer to monitoring treatment. But certainly protein is what we all care about. It just takes a little longer to develop.
We have just 2 more. We got about 5 more minutes left. But how long would you wait to start any immune treatment? My protein has gone from 5 to 7 and down to 4 in the past 4 months. Should I wait longer to see if I will drop down to 3 or below?
Yeah, I think and again, this is there are lots of other factors. What the blood albumin protein, if that's getting a little better, I'd certainly wait. If you had antibodies to follow, they're going down, I'd wait. The problem with checking the urine proteins is it is very variable. If you check 3 days in a row, you're probably going to get 3 different answers. These are all similar. And I think the fact that it's getting down to 4, I would probably wait. But again, there are other factors. If the kidney function were getting worse, that might be an impetus to start treatment earlier. Development of a blood clot. So it depends on a number of factors, and I wouldn't rush. I think that's the case. This disease plays out, and we see that the loss of kidney function isn't in the next few months. It's over years. So I think there is time to wait and figure out the trajectory of the disease before rushing into treatment. There was a study that came out from the CureGN network that just looked at treatment patterns for membranous nephropathy and other glomerular diseases. And a large proportion of patients in the United States were getting treated earlier than was recommended. So I would advocate waiting a little bit more unless something else is changing.
And the response was, that helps, by the way. My function is stable and blood albumin has gone up.
Great, that's a good sign.
I think we have one more here. If there's any questions post presentation, I'll actually, after we ask this question, I'll put my email address in the chat function, and we'll forward those along to Kelly and Dr. Beck, and hopefully get those answered in due time, and knowing that Dr. Beck's a very busy man as well. So let me see here. What's the view on I'm going to mispronounce this. Ofatumumab, which is in trial. Yes.
Yeah, I think that's, so there is another trial. This is another type. I can't say these. There are a number of anti-B cell agents, and hopefully they'll have nicknames. It's, they all target the same little protein on the B cell in different ways, and different ways of killing the B cells. This is, I think, one more humanized, meaning it's less likely to develop an allergic reaction to it, having your own immune system sort of getting rid of the antibody, the drug that's being given. And it's a little more of a potent killer of B cells. So I think people expect this to be a useful, a new medicine. but it will work similarly to rituximab. It may be a little quicker, a little more potent, or more patients might respond to it. But it's along that same line of anti-B cell agents that we know work very well already. So yeah, keep your eyes open for trials. I think it may still be recruiting, but there probably will be other anti-B cell agents out there. And until we get that one antigen-specific therapy that we can target exactly the B cells we want, I think this is a good way to go forward with these anti-CD20 or anti-B cell agents.
Excellent, thank you. I actually don't see any other questions, but if there are any after this presentation, or you think of something a few hours later, tomorrow morning, feel free to send it to my email address, bsmith@nephcure.org. We'll help you out. And please remember to sign up on Friday, August 27th. The FDA does want to hear from you, so really appreciate your time today, Dr. Beck. And I think you have 2 more slides, maybe, if you don't mind.
Now we can go to the sponsors.
Yep. Of course, we want to thank our sponsors today. You can see them all listed here, really helping out and everything we do here at NephCure. It can't be done without our pharmaceutical partners and also our sponsors and also our volunteers, people out there like you. We're getting a few thank yous coming in for you, Dr. Beck. So very much appreciated your time. Yeah, thank you so much for joining us today.